It gives me a great pleasure to present the next speaker, who is Dr. Noha Al Gohany. She is an assistant professor of internal medicine and rheumatology, Taiba University, Al Madinah Al Munawwara. She is going to talk about psoriatic arthritis and metabolic syndrome. Welcome, Dr. Noha.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizing committee for inviting me, and thank you for this nice organization. So how I can go?
The green one, in the middle.
So this is the outline for my lecture today that I will go through. So psoriatic arthritis is a heterogeneous disease. As we know that patients can present with different clinical domains. They can have arthritis, enthesitis, they can have skin or nail involvement. And as we can see that each domain have different clinical presentation, and it's caused by different combination of cytokines. So what is the importance of that? The importance of that knowing which domain is patient have open presentation is helping you to choose the optimal therapy for him. They thought for decades that psoriatic arthritis is a benign disease, but studies over the last 20 years changed this concept. It's what they thought that it's only the skin of the disease of the skin and joints. It's a systemic disease that has a great impact in your internal organs. So psoriatic arthritis is associated with many comorbidities. On top of that is cardiovascular disease, metabolic syndrome, fatty liver disease, inflammatory bowel disease. But we don't know till now really, is this simply just an extra-articular manifestation of the disease, or it's a complication of the disease? But what we know till now that if we control the systemic disease process, we might help to reduce these comorbidities. So half of patients with psoriatic arthritis, they have at least one comorbidity, which results in cardiovascular disease, decreased quality of life, and a huge impact on disease outcome. A meta-analysis which was done which showed that patients with psoriatic arthritis has a 43% increased risk of cardiovascular disease, 22% increased risk of stroke, and 55% increase your incidence of cardiovascular events. Obesity is one of the most common comorbid conditions that is usually associated with psoriatic disease. So obesity has a great impact on disease activity and poor treatment response. And what we can see on the figure in your right side, that psoriatic arthritis patient who lost more weight, they are high likely to achieve minimal disease activity. So if there is any association between obesity and the risk of developing psoriatic arthritis, this has been looked at in a large population-based study. And what they found, first on the left side, that they took psoriatic arthritis patients and they followed them over time. And they found that patients with psoriasis who had high BMI, they are at high likelihood of developing psoriatic arthritis. Then they looked also at the relative risk of developing psoriatic arthritis among general population. And what they found that patients who had high BMI, they are at high likelihood of developing psoriatic arthritis even among the general population. So what is the relation between obesity, psoriatic disease, and metabolic syndrome? It's complex. They all share the same pathway. They all share the same mediators. They considered as a pro-inflammatory condition. So what is the end result? that we have an accumulation of a lot of pro-inflammatory cytokines like adipokines, interleukin-6, and the tumor necrosis factor. So what is the end result? The end result that this all causes endothelial dysfunction, increase insulin resistance, stimulate your liver to produce more CRP, and this lead to atherosclerosis, increase your cardiovascular risk. An interesting finding in one of the studies that every 1 unit increase in your BMI is increase your likelihood of developing metabolic syndrome by 1.2. So what is a metabolic syndrome? According to the Cholesterol National Education Program, they defined metabolic syndrome if you have 3 out of the 5 of the following risk factors, which are abdominal obesity, triglyceride level, HDL cholesterol, blood pressure, and fasting glucose. So why we are worried about metabolic syndrome? A large US population study which has been done showed that increase your risk factors for cardiovascular disease, increase your hazard ratio of cardiovascular mortality. And as you can see here on this figure, the pointer is not working, that patients who have a metabolic syndrome, they have a hazard ratio of 2.6 of increased cardiovascular mortality. So how is common metabolic syndrome in patients with psoriatic arthritis? This is a cross-sectional study which includes 283 psoriatic arthritis patients matched to age and gender and ethnicity to 100 control patients. And they found that the prevalence of metabolic syndrome in patients with psoriatic arthritis is around 44%, and even after they adjust for BMI, the prevalence of metabolic syndrome is still high among psoriatic arthritis patients. So is there any difference in the component of the metabolic syndrome? So what we can see here that waist circumstances and high blood pressure, the last column, is the most significant one in psoriatic arthritis patients when we compare it to the general population. And half of psoriatic arthritis patients, they found that they are clustering 4 or more risk factors. So a second important question, is the metabolic syndrome associated with more severe disease? Also, this has been looked at in one of the studies that they include 283 patients, and they define severe disease as if the patient have any radiological damage or requiring anti-TNF therapy. And what they found that metabolic syndrome was associated with more severe PSA disease, higher smoking pack per year, and worse patient-reported quality of life. As we all know from the previous studies that metabolic syndrome has been also looked at in patients with rheumatoid arthritis, patients with ankylosing spondylitis, which showed that those patients, they are at higher risk of developing metabolic syndrome. So are there any difference between the different kinds of inflammatory arthritis? So this study compared the prevalence of metabolic syndrome among the 3 different types of inflammatory arthritis, and what they found that patients with psoriatic arthritis at higher risk of developing metabolic syndrome in comparison to patients with RA and ankylosing. Also, they compared the odds ratio among each type of inflammatory arthritis with age and sex matched control, and they found that patients with psoriatic arthritis, they have a likelihood of 2.5 to develop metabolic syndrome compared to general population, while there was no much difference between patients with ankylosing spondylitis and rheumatoid arthritis. And among the components of metabolic syndrome, when they compared the risk factor in patients with psoriatic arthritis compared to patients with rheumatoid and ankylosing spondylitis, central obesity, impaired fasting glucose, and high triglyceride and low HDL were the most significant one among patients with psoriatic arthritis. So as we mentioned earlier that metabolic syndrome increases your risk of cardiovascular disease. So are the patients with psoriatic arthritis with metabolic syndrome at a higher risk than the usual psoriatic arthritis patient? The relationship between that was studied in this study in Arthritis Care Research in 2014, which have looked to the relation between metabolic syndrome and carotid intima-medial thickness, which is a surrogate marker to detect early subclinical atherosclerosis. So they did carotid duplex ultrasound on 98 patients with psoriatic arthritis and 117 patients with psoriasis. And if we look to the figure here, the dark blue one is the patient with no metabolic syndrome, and the light blue one is the patient with metabolic syndrome. So as we can see that psoriatic arthritis patient with metabolic syndrome, they have a higher carotid intima-medial thickness, and also if we look to psoriasis patient, they have a higher carotid intima-medial thickness. But what if we compared psoriatic arthritis patient to all other groups? They found that psoriatic arthritis patients with metabolic syndrome had the thickest carotid intima-medial thickness compared to any other group, with a significant p-value and the highest prevalence of a number of plague compared to any other groups. So, is the metabolic syndrome has an impact on the outcome of the disease? And this is what we are interested in. So they looked at the association between metabolic syndrome and achieving minimal disease activity. And as you can see on the figure here, starting from the time 0, that patients who had metabolic syndrome are less likely to achieve minimal disease activity, while patients who have absent metabolic syndrome, they are at higher likelihood of achieving minimal disease activity. And if you notice that with time, this becomes more and more significant. So then they looked to the predictor for minimal disease activity, and they found that there is an inverse relationship between having metabolic syndrome and the duration of the disease and achieving minimal disease activity. So patients who had a metabolic syndrome and who had longer disease duration, they are less likely to achieve minimal disease activity. And as we can see, even on multivariate analysis, this is still significant. So when we're treating patients with psoriatic arthritis, are we improving the metabolic syndrome component? So this is an observational study that has looked to patients with psoriatic arthritis who have a metabolic syndrome. So a total of 130 patients with psoriatic arthritis who diagnosed to have metabolic syndrome. They divide the patient to 3 groups. First group, 48 patients on methotrexate. Second group, 44 patients on etanercept. And the third group, 38 patients on adalimumab. This was starting at time 0, then they followed them over 2 years. As you can see that patient on methotrexate group, there is not much difference over time, but there was a trend of some improvement in patient on etanercept group and also on adalimumab group, with more drop in patients over time. They looked at the component, which component has improved over time, and they found that there is a trend toward reduction in weight circumstances, in triglyceride serum level, and in glucose, and also a trend toward increase in HDL in etanercept and adalimumab group when compared to methotrexate group. So now we are recognizing that metabolic syndrome consists a big comorbid condition in patients with psoriatic arthritis. So what is the solution? So what EULAR recommend in 2015, which is the last recommendation to treat cardiovascular disease, that every patient with psoriatic arthritis, you should control his disease activity optimally in order to reduce your risk of cardiovascular disease in your patient. And the assessment should be ideally at least every 5 years. And this can be changed if you find your patient at high risk, treat him immediately. If your patient at low or moderate risk, you can screen him sooner within 1 year. And if you change his therapy, you should again screen your patient for comorbidities. You should measure the patient's lipid profile even if his disease is inactive or in remission. And once you discover that your patient has a high blood pressure, start him on therapy. Encourage your patient for lifestyle medication. Should emphasize the benefits of a healthy diet, regular exercise, and smoking cessation for all patients. So what is the summary of my talk? The prevalence of metabolic syndrome is much higher in patients with psoriatic arthritis than those with psoriasis or healthy controls. People with psoriatic arthritis and metabolic syndrome tend to have more severe disease and lower likelihood of achieving minimal disease activity. The management of cardiovascular disease and metabolic syndrome can be optimized through improving adherence to healthier lifestyle among patients and understanding the impact of therapy on PSA outcome of the disease. But we still need additional further study on patients with psoriatic arthritis and metabolic syndrome. As you can observe, most of the study that I presented is an observational study. We need a well-designed study that have looked at the impact of therapy on outcome of the disease, especially cardiovascular disease and metabolic comorbidities. And the last thing, don't forget the multidisciplinary approach. Don't only treat the disease, treat the patient. If you discover that your patient has a problem, refer him to the appropriate service that they can take care of the patient, collaborate with the dermatologist for optimal choice of therapy and for optimal outcome of the disease. Thank you.
Thank you, Dr. Ara. Thank you, Dr. Ara, for this excellent talk. We'll open